Okay, hello all. Welcome to our Global SRH webinar. I'm SPIRHR. I'm from the Planning and SRH Fellow, and I'm honored to moderate this webinar on global abortion policies and its effect on maternal health. This is one of the series of our webinars on global SRH. It is organized by St. Paul Institute for Practice Health and Rights and in collaboration with our hospital, St. Paul Hospital Medical College. Today we are going to have three distinguished speakers. So our first speaker is going to be Dr. Tesfaye Hurissa. He is my mentoring friend. So Dr. Tesfaye Hurissa is an associate professor of obstetrics and gynecology with specialty training in family planning and reproductive health. He has more than 11 years of national and global experience in reproductive health with a special interest in research, policy, and programmatic works. He has published scholarly researches in both national and global reputable journals. Currently, he's serving as a director of St. Paul's Institute for Practical Health and Rights. Our second speaker is going to be Dr. Antonella Lavlanet, and she is from the World Health Organization, and her topic to talk about is going to be human rights law and policy. Dr. Antonella Lavlanet is a medical officer in the Prevention of Unsafe Abortion Unit at the World Health Organization in the Department of Sexual and Reproductive Health and Research. Before coming to WHO, Dr. Lavlanet worked primarily as a second trimester abortion provider, an advocate and family planning specialist in Massachusetts. And Dr. Lavlanet also has a law and policy background, and her interest includes laws, policies, and human rights related to quality abortion care, as well as clinical and policy implementation research. Our final panelist is going to be Tushella Seni, and she is a distinguished scholar and vice president for global science and policy integration of the Guttmacher Institute. She joined the institute in 1985 and was vice president for international research before recently transitioning in 2020 to join the office of the president. She's a demographer and a sociologist by training, and her research addresses a range of areas including abortion and unintended pregnancy, abortion-related morbidity, the costs and benefits of providing sexual and reproductive health service, maternal health, contraceptive use, and adolescent and sexual and reproductive health. She currently focuses on building relationship with key global SRH stakeholders, increasing connections between Guttmacher's domestic and international portfolios, and on maximizing the impact of institute research at global, regional, and country levels through its global policy and program. All our speakers are going to have 20 to 30 minute talk on different topics. So the first speaker is going to be Dr. Tesfaye. I will thank you to be one of our distinguished speakers in our webinar. And the title that Dr. Tesfaye is going to talk is on global abortion policy and effect on maternal health. Over to you, Dr. Tesfaye.
Okay, good afternoon, good morning, wherever you are. Thank you very much, Dr. Magdas, for the very warm introduction. So as it has been introduced, I will be talking about global abortion policy and effect on maternal health. So I have nothing to declare. So for the next few minutes, I'll be talking about magnitude of unsafe abortion, WHO Global Abortion Policy Database, and then finally abortion policies and effect on maternal health. So as an introduction, nearly 1/3 of all clinically detected pregnancies end in abortion, and more than half of unintended pregnancy again end in induced abortion. So we can confidently say that abortion is one of the commonest phenomena for women in their reproductive age. So considering this as one of the most important phenomena event in a woman's reproductive age, WHO has included comprehensive abortion care as an essential healthcare service since 2020. So this critically important event in the woman's reproductive age, this quite common event in the woman's reproductive age, has been restricted across the globe by different laws. So it doesn't make any legal or public health sense, especially some of this restrictive law. It will be very difficult to associate them to give, any public health or legal sense out of it. There is a general fact. This fact is that abortion is safe when it is simple and easily accessible. However, as we all know, this road is usually very long and difficult. Let's see some of the historical reasons for restricting abortions. So in the previous years, abortion was restricted to save life of the woman. This was true specifically in old age when we didn't have modern abortion medications, modern abortion procedures. So women has women has the interest of controlling their reproduction, but there were no modern medication and modern procedure. As a result, all abortion procedures were used to be very dangerous, and women has lost their life in the process. So that was one of the historical reasons to deny or to restrict abortion. And in another period, abortion was also considered as a sin or a form of transgression of morality. And these laws were intended to punish and act as a deterrent. In some circumstances, again, abortion was restricted to protect a fetal life. So these are, the historical perspectives of, reasons for restricting abortion. So in modern years, with the development of medication, with the development of new abortion, techniques, very safe abortion techniques, still significant percentage of abortion continue to be unsafe. So as a report by the World Health Organization, you can see that 45% of all induced abortion worldwide are unsafe. So this is in the presence of well-demonstrated efficacious abortion medication and well-demonstrated abortion procedures that are demonstrated to be safe and effective. Regardless, nearly half of induced abortion worldwide has continued to be unsafe and continue to take women's life. Unfortunately, there is a huge disparity between developing countries and developed countries when it comes to the rate of unsafe abortion. So as you can see by this report from World Health Organization, 97% of unsafe abortion occur in developing countries. This is mainly related to the access issue. So in areas where access is easy, abortion laws are less restricted, then abortion tends to be safe. So how is the context in Ethiopia? So as you know, Ethiopia as a country changed its abortion law in 2006 to incorporate broad range of indication to allow women to access an abortion. So subsequently, there were studies conducted to see how abortion-related maternal days has changed over the years. So before the change in this law, abortion-related maternal days used to contribute more than 1/3 of abortion-related mortality. Over the years, this has reduced to be as low as less than 5%. So as per the report from the Health Sector Transformation Plan 2018, only 4% of maternal days is attributed to unsafe abortion. So this huge, remarkable change has been brought mainly by legal reform, but there were, huge contribution from policymakers, from parliamentarians, from researchers, from clinicians. So all stakeholders, including local partners, has contributed enormously for this change to be brought in Ethiopia. So let's talk a little bit about the WHO Global Abortion Policy database. So this is an online open access policy database which shows the policy with regards to reproductive health of countries across the globe. So what is the purpose of having this abortion policy database. So it is launched initially actually in 2017, and it has been used for the past 4 or 5 years by World Health Organization. This WHO Global Abortion Policy Database has aimed in promoting greater transparency of abortion law and policies. So you can go into this database and see what abortion policy a country has, what are the working documents, which documents are ratified, and all detailed information with regards to abortion is incorporated in this global abortion policy database. So this will improve countries' accountability for the protection of women and girls' health and human rights. So let me take you to this global abortion policy database so that you can see how this online platform can be utilized and can be used for different purposes. Okay, so this is a WHO Global Abortion Policy Database interface. So you can see there is a world view, country comparison, and there is an option to select an individual country. And you can see the world map here. When you go down, you can see policy and legal sources related to abortion in different regions. Concluding observations are here. Important documents, that this is a newly launched abortion care guideline. And if you go down, you can see different research and publication related to this database. So let me just give an example and see one country and show you how you can see the abortion-related policy of and working condition of the country. So let's just take Ethiopia as an example. So we write Ethiopia here. And then, so this is the country profile of Ethiopia. So as you can see, the last update was on 22nd April 2020. So here you can see lists of ratified human rights treaties, including the Maputo protocols and other documents. And when you go down, here is a question which asks if abortion is allowed at the woman's request. So, and here you can see the legal ground and gestational age limit. So here you can see different lists of indication and if it is allowed to have an abortion under these indications. So for example, it's not allowed to have abortion as an economic reason, but fetal impairment, rape, incest, intellectual or cognitive disability of the woman can be used as a legal ground to access abortion service in Ethiopia. So these are additional requirements to access safe abortion. So you can go down through this area and you can see some information regarding consciousness objection and other important legal working condition in the country. So you can see how important this global abortion policy database, and you can just put a country and you can get all information you need about that country in line with abortion. So going back here, so this WHO Global Abortion Policy Database, as you can see, it's a very important and it's a very important document to get especially abortion-related information on a country, and there is in fact a place to send an update and correction. So if you find something which is not updated regarding your country, you can actually send an update and it will be automatically corrected by experts at the World Health Organization. The most other important input of this global abortion policy database is it is actually serving as a source for important abortion-related research. So here you can see a research conducted by experts from World Health Organization. This is a descriptive analysis of the legal categories of laws of lawful abortion. So there are some interesting findings from this study. So for example, one of the outcomes of this study says that 32% of countries permit abortion at the woman's request with no requirement for justification. And 82% of countries permit abortion to save the woman's life. Again, 64% of countries specify physical or mental health as an indication to access abortion, and 51% allow abortion based on fetal condition. And 10% of countries specify economic or social ground as a reason to allow abortion. So I call upon all the participants, the audiences to use this platform to get an information about the country, to use it as an input for your research undertakings. So there is a big question here. So what is the logic, or what is the ground to have several abortion laws throughout the world? At the beginning of our discussion, we talked that abortion is one of the main phenomena in the reproductive age of a woman. So why is it important to have this variety of laws on a very basic human right issue, which is determining when to have a child, when not to have a child, and when to terminate the pregnancy? So across the globe, you can see varieties of spectrum of laws. In some countries, abortion is literally inaccessible, or the laws doesn't literally allow a woman to have an abortion, while in other countries, abortion can be accessed on demand. So what is the reason, or why do people restrict abortion? So two main reasons are widely attributed as one of the reasons for restricting abortion. There is one strong belief that is, by restricting abortion, people believe that they will reduce occurrence of abortion. The other strong belief is protection of maternal health. So regarding reduction of occurrence of abortion, probably my colleagues, the next speakers, may say a little bit more about it, but let me say, put my points, how restricting abortion actually protect maternal health. And let us see how this claim is justified by studies and by research. So according to the World Health Organization, 4.7 to 13.2% of maternal deaths each year is attributed to unsafe abortion. So this is a significant proportion of maternal deaths which is contributed by unsafe abortion. Again, this rate has a discrepancy between countries. So in developed countries, only 30 per 100,000 abortion-related maternal deaths occur, while 220 per 100,000 abortion-related deaths occur in developing countries. So this is nearly 8-9-fold difference between the developing and developed country. So how does abortion law affect this maternal mortality? So this is one study, an ecological study, which is conducted in 162 countries. So this study compared the flexibility score in a country with regards to the maternal mortality. So this flexibility score is a score which is used to show how the country is flexible towards abortion, or how broad indications are there to grant a woman abortion service. So high flexibility score means a country has a better flexibility, or a better access, gives a better access to a woman to access an abortion. So over a period of years, the finding of this study was interesting. So in these 165 countries, over the period of, you can see, starting from 1985 to 2013, you can see the flexibility score has increased from 3 to 4. So that you can see a gradual increase in flexibility score. At the same time, you can see a gradual reduction in maternal mortality. So as a country, laws give more freedom, more access to abortion service, it seems obvious that the maternal mortality of a country will be reduced. So restricting abortion, there are actually several other similar studies. This is just one example of similar studies. So this is just an example to justify that actually restricting abortion doesn't prevent maternal health or doesn't prevent maternal death. It actually increases maternal mortality. So by increasing access, by providing more access to abortion, we can actually reduce abortion-related maternal mortality as well as maternal mortality in general. So we can pull several similar studies. The other thing is that I want to talk is abortion law versus access. So the common understanding is, a common fact is, when abortion laws are, more liberalized, then access to abortion will increase. This is a fact, across the world. But here I want to pull an example that shows merely having a good law doesn't grant an access. So this interesting study compares 3 countries, so Zambia, Ethiopia, and Tanzania. So I will talk about the 2 extremes, Zambia and Tanzania. So on this study, as you know, Zambia, this study suggests that Zambia, this was one of very liberal country in terms of abortion, while Tanzania is the other extreme where abortion is quite very restricted on the law. And Ethiopia has a pro-liberal kind of abortion law. But how does abortion law, affects access is demonstrated in a paradoxical way in this example. So Zambia, despite having a very good law of abortion with broad indications, but to access an abortion, a woman actually needs a signature from 3 physicians. So despite having a good law, again, the woman should have a signatory from 3 physicians to access abortion. So in this paper, it gives an example of a rural hospital in Zambia. So in a rural area of Zambia where there is no, you can imagine when there is no one single physician, looking for a signature from 3 physicians to access abortion. So despite the law, literally access is very much limited in Zambia. But let's go to the other extreme of Tanzania. So in Tanzania, the law is it's one of very restrictive laws in Africa. But a provider to provide an abortion service, it doesn't need a signature from a physician or any other body. So physicians are very committed, dedicated to provide abortion without any problem. And other local partner also has contributed to this. So despite a highly restrictive law in Tanzania, women access abortion much better. Again, in Ethiopia, similar to Tanzania, the law is not fully liberalized, but the providers and other local partners work very hardly, to grant access to abortion for a woman without any limitation. So this study gives an important insight that the only, merely changing abortion law to make it liberal doesn't grant access. The health system should be ready. The health system should be suitable for a woman to access abortion beyond, having a suitable law. Finally, I want to say a few words about decriminalization of abortion. So the final aim of, stakeholders fighting for reproductive health and rights is to decriminalize abortion. So what do we mean by decriminalization of abortion? Decriminalization of abortion is treating abortion similar to other medical conditions, other medical circumstances. So this is, using best practices in service delivery, training of healthcare providers involved in abortion care, and development and application of evidence-based guidelines to improve, access and to improve provision of safe abortion service. So legalizing abortion is not decriminalizing abortion. So what we are hoping for is treating abortion as other medical conditions and removing it from any kind of restricting restrictive laws. So far, only Canada has successfully decriminalized abortion, but the hope is towards increasing access by decriminalizing abortion in order to reduce this high burden of abortion-related maternal deaths, as well as ensuring the right of women to use a reproductive privilege to the maximum. So abortion is safer more than ever if it is done, if it is handled well, and if the woman has full access to it without any restrictive law. And we do have evidences that increasing access to safe abortion reduces maternal mortality ratio or maternal mortality. So as a reproductive health advocate, I call upon reproductive health researchers, policymakers, and influencers to put their mark in order to, in the direction of increasing access to safe abortion service so that women exercise their reproductive right to the maximum. Thank you very much.
Thank you very much, Dr. Tesfaye, for your nice talk on global abortion policy and effect on maternal health, and especially focusing on our Ethiopian context, how the change in law brings a maternal death reduction, and also about abortion access and health system. So if there are any questions, we are going to have them at the end of all the presentations. So second, I call upon Dr. Antonella Larnet from WHO for our talk on human rights law and policy. And Dr. Antonella, please, over you.
Thank you for inviting me to be here with you today. I feel very privileged and excited to be here with you. My name is Dr. Antonella Lavlanet, and I'm a medical officer with the Prevention of Unsafe Abortion Unit in the Department of Sexual and Reproductive Health and Research. Today, I'd like to review some human rights standards with you and provide some examples of legal and policy reform. I'd also like to discuss ways in which WHO has supported evidence collection as it relates to legal and policy reform, and discuss political will and continued advocacy. As many of you know, we recently launched the Abortion Care Guideline. And within the guideline, we recognize that a person's environment plays a crucial role in shaping their access to care and influencing their health outcomes. Thus, an enabling environment is the foundation of quality, comprehensive abortion care, and includes respect for human rights, including a supportive framework of law and policy, the availability and accessibility of information, and a supportive, universally accessible, affordable, and well-functioning health system. All of these components are important, but today I'm going to briefly focus on the first point, respect for human rights, and provide some examples of law and policy frameworks in various settings. When we speak of human rights, we include the rights to life, liberty, autonomy, and security of the person, the right to non-discrimination and equality, the right to information and education, and the right to privacy, among others. This also includes the right to the highest attainable standard of health. Here in italics, you can see WHO's definition of health. This definition also applies to sexual and reproductive health. While all member states accept this definition of health, many countries' laws do not actually refer to either the definition or reference explicitly all component parts of health: physical, mental, and social well-being, and not merely the absence of disease. When we speak of this right to the highest attainable standard of health, this includes both freedoms and entitlements. Freedoms to control one's body, sexual and reproductive rights as well, and to be free from interference, and entitlements, including the right to protection that gives everyone equal opportunity to enjoy this highest attainable standard of health. But more specifically, when we speak of reproductive rights, we're speaking of the right of couples and individuals to access information and the means to decide when, how, and if they want children, the right to consensual partnership, and the right to benefit from scientific progress. So how do we deliver on this? sexual and reproductive health services, in particular abortion services, that are evidence-based and protect, respect, and fulfill human rights. Through our guidelines, as well as through our policy dialogues, WHO helps governments and health policy makers improve sexual health through bringing their laws and policies into alignment with their own constitutional and international human rights obligations. We provide technical, intellectual, and political leadership because WHO has made a commitment to mainstream human rights into healthcare programs and policies on national and regional levels. Specifically then, on the basis of human rights standards, and in order to safeguard sexual health and well-being, the following are some of the human rights standards and law and policy considerations we ask states to consider, especially where legal entitlements that speak to access to abortion care exist. So states must take steps to reduce maternal mortality and morbidity, especially as it relates to unsafe abortion. Where it's lawful, abortion must be safe and accessible, and states must ensure that equality and non-discrimination exists in the provision of sexual and reproductive health care. Care must be accessible to all, so that includes children and adolescents. And additional groups we ask states to consider are people who are unmarried or cannot marry because of the law, those in prison and other detention facilities, migrants and asylum seekers, or others living in humanitarian contexts, people living with HIV, people living with disabilities, people with same-sex sexual orientation, transgender, gender variant, and intersex people, and people engaged in sex work, just to name a few. So specifically, we ask countries to consider whether laws, regulations, and/or policies guarantee the provision of comprehensive health services in relation to sexuality and sexual health. And more specifically, do national human rights standards and/or laws guarantee access to essential medicines, that the exercise of conscientious objection, for example, does not jeopardize people's access to health services in relation to sexual health. The categories of healthcare providers who can provide certain services related to sexuality and sexual health are not restricted if appropriately trained. Can these individuals deliver services safely and efficiently? With abortion, it's important to note that unlike many other healthcare services, it is most often regulated in the penal code in almost every country in the world. Thus, we also ask countries to consider the negative health, including sexual health consequences of criminalization on the provision of sexual and reproductive health services and the criminalization of consensual sexual activity. Here are a few others. States should ensure that appropriate services are available for those who have been exposed to sexual violence. And states must provide post-abortion care in all circumstances, including where abortion is illegal. States should also ensure that laws regulating abortion are evidence-based and proportionate, protect the right to health, and protect persons' physical and mental integrity. Some of these are positive obligations, things that states must do to fulfill their obligations. We also work with states to consider the ways in which services are structured and accessed. So for example, some of the components we ask states to consider when they're establishing service provision include training and equipping. Pre-service and in-service training is needed. Clinical guidelines, which include evidence-based information, is critical, not only to inform on how, but also where, who, and what can be provided. Individuals should be supported to appreciate their professional responsibilities and how those align or don't align with their personal views. When we consider financing and costs, for example, this includes reproductive health technologies, appropriate allocations for staff time, and ensuring that sexual and reproductive health services, including contraception, are never to be denied or delayed due to a person's inability to pay. Monitoring and quality assurance are important, which means not only collecting service statistics, but also doing case reviews, direct observation, interviews with service providers and users, all with the goals of ensuring that service provision align with standards and guidelines, and that services are actually responding to the needs of users and providers. This promotes system readiness, preparedness, and responsiveness. Many of these components are addressed within national law and policy frameworks. However, when it comes to abortion, there are many relevant laws and policies to consider. As highlighted earlier by Tesfaye, in 2017, WHO launched the Global Abortion Policies Database, and it's meant to provide details related to the legal categories for abortion, gestational limits, and other access requirements. It includes the country abortion laws for all UN member states, linked to downloadable source documents, juxtaposed to relevant WHO guidance, signed human rights treaties and all concluding observations related to abortion, 18 country health and rights indicators, as well as relevant sustainable development goals. The database is currently being updated at the moment, but it allows us to access current law and policy environments in country, as well as changes that have occurred. But change can come in many forms. They can be sweeping or they can be incremental. So now I'd like to focus on some examples of various law and policy reforms that have happened in the recent past in various countries. Some of you may have heard about the changes in places like Argentina, or more recently in Mexico, or even Ireland 2 years ago now. In these places, abortion became available on request for individuals less than 12 to 14 weeks, depending on the country. As an aside, these countries are great examples of social or collective mobilization. It's because of this that change was possible. But as mentioned, change happens in all sorts of ways and has happened in many other countries. For example, in South Australia, individuals accessing or providing legal abortion can now do so without the threat of criminalization. Criminal penalties do remain, however, for those who practice outside the scope of abortion law. Some might wonder whether that is not a positive thing, i.e. punishing people for practicing outside the scope of law. However, this highlights that unlike many other health procedures, abortion is regulated through the criminal law and not healthcare law. For other services, those who provide services outside the scope of medical mandates often face professional sanctions. In New Zealand, for example, the law has changed so that there are no legal restrictions on abortion up to 20 weeks, as abortion services form part of medically required health service provision and are regulated as such. Abortion is also available after 20 weeks, but additional requirements apply. In North Macedonia, a new law came into effect, which increased the gestational limit for women to be able to access abortion on request from 10 to 12 weeks. It removed the obligation for judicial authorization in cases of rape, the legal requirement for compulsory counseling and the waiting period, and the previous requirement that there must be 1 year spacing between abortions. Again, many of these requirements, which still exist in many settings, are unique to abortion. In India, a recent amendment has been published which increased the gestational limit within which a woman can obtain services, including cases such as where there's a threat to the woman's physical or mental health or a serious fetal anomaly. At the same time, however, there are new requirements related to the need for additional authorizations. In areas of the country, especially rural areas, obtaining these additional authorizations may be difficult. Other countries have also added additional barriers or further restricted access in a variety of ways, which impacts on reproductive rights and health. In Poland, the Polish Constitutional Tribunal declared that one of the 3 exceptions which had been previously allowed is now unconstitutional. So abortion is no longer available for cases of fetal anomaly and is only legal where the pregnancy poses a threat to the life or health of a woman, or when the pregnancy resulted from a prohibited act such as rape or incest. You may have seen recently that the restrictive environment there contributed to the death of a woman who became infected when she miscarried, but no doctor would treat her until there was no longer a fetal heartbeat. They were too late, and this example is not unique to Poland. In Brazil, new requirements introduced in 2020 impose a 4-stage authorization process for those accessing abortion due to sexual violence. This includes the woman seeking an abortion describing the crime she experienced to 2 health professionals who must take detailed notes, conduct a thorough medical assessment, including carrying out several tests, some of which are unnecessary for abortion care provision. The health professionals are obliged to report the crime to the police. Subsequent to this, she must also be assessed by a multidisciplinary team comprised of several workers, including a nurse, a social worker, and a psychologist. This is quite an onerous process, not to mention the associated stigma and shame related to the violence and potential further traumatization by healthcare workers. It's also important to note that some states have very focused law or policy regulations which they've worked on to improve access to care. So in countries like Zimbabwe, for example, minors are defined as anyone under the age of 16 and individuals who can make decisions on their own. Other countries like South Africa have included language in their laws that allow abortion on a minor without parental consent, although the minor is advised to consult with her parents. However, if she decides not to, she cannot be refused. Similarly, in terms of thinking about equitable access, in particular as it relates to access to providers, some countries like Nepal, Benin, or Ghana include an expanded range of workers who can provide abortion-related services. This can include individuals such as auxiliary health, nurse midwives, licensed health workers who have fulfilled prescribed standards and qualifications, These are just some examples. In line with our guidance that says services should be available at the primary care level, some states have specified this specifically in their laws or policies. Examples include Bangladesh, Cambodia, and Ireland, but there are many others. And other countries are trying to work with the regulation of conscientious objection by specifying, for example, that if there is no available service provider, the individual seeking abortion must be transferred to another health unit where they can access care, or that contact details of an abortion service provider must be given to the woman and all medical files must be available to the new provider, or that facilities must ensure that abortion services are available regardless of whether individuals who refuse to provide care are employed there. So we have all these examples. Now what? Well, it means that we continue to work with countries. Evidence from countries around the world demonstrates that we must work with governments so that they can appreciate the health impacts of laws and policies. And impacts can be broad, everything from delay, resort to unsafe abortion, disproportionate impact, but also anticipated family disharmony or violence, for example. Additionally, we have found in our research that without political will, advancing in this issue, and in particular towards progressive realization of human rights, is almost impossible. Finally, even with legal and policy reform, sustained advocacy efforts are needed. So we continue to work with partners to ask questions like, are these laws and policies doing what they're supposed to, or are they creating additional barriers for abortion seekers? I'll just review a couple of examples. WHO recently supported a study which examined the factors that account for the implementation, scale-up, and sustainability of an expanded abortion service following the legal reform in the Republic of Ireland. And this provided an understanding of the barriers and facilitators to the implementation process. 108 interviews were conducted with healthcare service providers, service users, and key informants. Secondary internet data were also used were collected and assessed. The study found that overall, the community abortion service model is working well from the perspective of both providers and service users. Providers found abortion healthcare to be rewarding, and they were grateful to be able to help women in Ireland rather than having to send them abroad. Two particularly successful strategies were identified that facilitated abortion policy implementation through support of providers and service users. This was proactive support offered to providers by quote unquote cocooning them to assist them in resolving early problems or queries, and also the development of something called the My Options free phone line, which is a national helpline which operates 6 days a week, where women and pregnant individuals looking for abortion care in Ireland can call free of charge and receive the name and phone number to specific providers near them. While GPs or general practitioners did have issues with being overworked, midwives and nurses were among the champions who took on leadership roles to set up hospital services. Remaining challenges do exist, though. Some individuals were unaware of or could not remember My Options as a national referral service. Timely appointments at clinics may be unavailable, and pathways to available GPs are often difficult to find. There's also an uneven or incomplete geographic coverage of abortion services, both in the community and in hospitals, but in particular in rural regions in the west and north of Ireland. Individuals in need of translation services and migrants are disproportionately impacted, and there's an over-reliance on theaters for surgical procedures with general anesthesia and a greater need for ambulatory gynecological services. Despite overall support for legal reform, there remains a significant number of conscientious objectors, especially in maternity units, creating the need to maneuver schedules and staffing around objectors in order to work out viable schedules in the operating room. Stigma and fear, especially of legal repercussions, persist, and values clarification exercises have consistently proved valuable by providing the open communication platform to encourage providers and non-providers to reflect about abortion service provision, and additional services are desired here. All of this information is now being provided to the Irish government, who is undertaking a review of all available information related to their legal reform in an effort to assess service provision. Similarly, we recently published findings from a study conducted in 17 countries across sub-Saharan Africa and the Latin American region. And in Africa, the study was conducted in 211 facilities, and in Latin America in 70 facilities. In summary, based on the indicators present at the time of facility admission, abortion-related complications were classified into 5 hierarchical and mutually exclusive categories based on severity, going from being very severe maternal outcomes consisting of mortality and near miss to mild complications. Across sub-Saharan Africa and Latin America, the findings illustrate that the majority of complications were moderate and mild, and marginally more severe complications were present in sub-Saharan Africa. Women's experiences of abortion care across both regions underlined the need for effective communication and emotional support, including reducing anxiety and stress during examinations. Additionally, as mentioned, political will is critical. We saw this, for example, when we supported a 6-country case study, which included Colombia, Ethiopia, Ghana, Portugal, South Africa, and Uruguay, where we assessed policy and program innovations related to law reform and implementation. Following legal reform and the introduction of new services, documenting the subsequent declines in abortion-related morbidity and mortality provided evidence to support both the public health and human rights cases for safe abortion in all 6 countries. Political will and local ownership emerged as key ingredients for successful policy reform and its comprehensive and enduring implementation. So now let's circle back to the abortion care guideline. Today, I provided some examples of various legal and policy environments. Many of these examples demonstrate steps countries have already taken towards respect for human rights, including a supportive framework of law and policy. There are, of course, specific recommendations that are now included in the guideline that speak to this as well. But recognizing that the legal, regulatory, policy, and service delivery context may vary from country to country means that there are various steps that countries can take towards ensuring and enabling regulatory and policy environment and the implementation of quality abortion care. It's important to remember that multiple actions are needed, not only at the legal, but also the health system and community levels, so that everyone who needs it has access to comprehensive abortion care. And at this point, I would refer you back to the updated guideline, which reflects recent evidence on the comprehensive abortion care across the continuum of care, including the provision of information, abortion management, including for different clinical indications, and post-abortion care, including follow-up care, treatment of complications, and post-abortion contraception. Thank you, and I look forward to receiving your questions.
Okay, thank you very much, Dr. Antonella Lavlanet, for your nice lecture. I hope we all learn a lot about countries' reform of abortion law and how the care delivery to abortion service really has a lot of can be affected by a lot of things, and about of the safety and the quality of abortion service. I think if there are any questions and comments, again, it's going to be at the end. So I'm going to give the floor for our next speaker, to Sushela Sini, and it's going to be the talk on global evidence on abortion and the role of data in advancing safety and access and equality. So I think Dr. Sushela, you can continue.
Thank you very much for the opportunity to be part of this important event. I'm looking forward to providing a global perspective on evidence on abortion, and in particular, the role of data in advancing safety, access, and quality of safe abortion care. First, I will start by providing an overview about what we know about abortion rates globally, and how this relates to abortion policies in the global landscape. Fortunately, we have new global estimates of abortion and unintended pregnancy to help us do this. Guttmacher and WHO collaborated to update global and regional estimates, and these model-based estimates were released in July 2020. And for the first time, the model was extended to produce country-level estimates, and these were released just last month by Guttmacher and WHO. Today, the 3 main points we will cover are the following. First, unintended pregnancy and abortion, are experiences shared by people around the world. Second, ensuring access to legal abortion services is essential, and it is equally important to prioritize provision of contraceptive care. And third, country-specific data are essential for informing policies and programs that can improve safety, access to and quality of safe abortion care, and quality contraceptive services. Turning now to some key data points. Abortion occurs in all regions and countries without exception. It is an experience shared by people around the world. This figure shows estimates according to the legal status of abortion. On the left are countries where abortion is broadly legal, and the three categories to the right show estimates for groups of countries where abortion is restricted. In the three categories with restrictive abortion laws, unintended pregnancy rates range from 70 to 80 per 1,000 women per year. This is higher than the rate of 58 in countries where abortion is broadly legal and where contraceptive use is higher. Where abortion is restricted, the abortion rate ranged from 36 to 40. And this is similar to the abortion rate in broadly legal countries, which is a rate of 40. These findings tell us that abortion is needed and sought, even in settings where it is restricted. They also tell us that contraceptive services need to be prioritized. While abortion rates do not vary based on the abortion law status, abortions in countries where it is legally restricted are more likely to be unsafe. This chart shows that while 87% of abortions are safe in countries in which abortion is broadly legal, only 25% of abortions are safe in countries where it is most restricted, the third bar on this chart. And more unsafe abortions mean more women in need of essential and life-saving post-abortion care services. As of 2019, an estimated 20 million women experienced complications from unsafe abortion in a one-year period. Among these women, about 42% did not receive treatment for those complications. This figure shows the worldwide trend from 1990 to 2019 in both unintended pregnancy and abortion rates. What we see is that unintended pregnancy declined substantially from a rate of 79 to a rate of 64 over these 3 decades. This is due to increased use of contraception and reflects motivation to achieve childbearing goals. However, the abortion rate showed no decline over this period, and this is likely due to the desire for smaller families increasing at a faster pace than the rise in contraceptive use. I'm going to turn now to make a few broad points about how data can be brought to bear to improve sexual and reproductive health policies and programs. Data are essential for monitoring the availability, accessibility, and quality of abortion services. Here we outline the kinds of data that need to be collected to inform and facilitate evidence-based policy and programmatic decisions. Ongoing systematic collection of data from health facilities, including hospitals, is necessary to monitor access and quality to the existing services. Qualitative studies are valuable for getting a deeper understanding of an issue, and they can include in-depth interviews, focus group discussions, and other approaches. This type of study is appropriate for gaining insight into the perspectives and barriers that exist from people who need and use services, as well as from providers. Such studies can address issues such as barriers to accessing legally permitted services and the quality of care among those who used the services. Quantitative studies are also needed. For example, reproductive health surveys are essential for understanding fertility preferences and reproductive behaviors and outcomes, and for measuring unmet need for sexual and reproductive health services. Country-specific data are critical for improving our understanding of abortion and how policies and programs can meet gaps and improve care. For example, such data are important for helping us understand the variation across countries, within regions, in the incidence of abortion. And this chart is based on the new data that were recently released. It shows how Ethiopia compares with other countries in East Africa. The annual abortion rate in Ethiopia for 2015 to 2019 is an estimated 24 abortions per 1,000 women 15 to 49 years of age. Ethiopia has a relatively low rate of abortion compared to the East Africa regional rate of 35 per 1,000 women, and compared to several other countries shown here. Let me now discuss a couple of examples of how data and evidence can help monitor access to abortion services and quality of care, and can help to identify gaps in the provision of services. In India, abortion is broadly legal, but we found that many facilities were performing abortions using procedures not recommended by WHO, and this was based on a survey of health facilities in 6 states. WHO recommends medication abortion and vacuum aspiration procedures for first trimester abortion, and it recommends either medication abortion or dilation and evacuation, referred to as D&E, for second trimester abortion. Dilation and curettage, referred to as D&C, is not recommended for abortion at any gestation. What we see here is that a substantial proportion of all facility-based procedures were done using either D&E or D&C, ranging between 25% and 38% across the 6 states. But only 4% to 13% of all facility-based abortions were in the second trimester. So the high proportion done using D&E or D&C indicates that a substantial proportion of abortions in facilities were being done by more invasive procedures than should have been the case. Here we compare results from 2 health facility surveys conducted in Ethiopia in 2008 and 2014. We see substantial progress in increasing access to facility-based abortions. We found that while only 27% of abortions took place in a health facility in 2008, this increased to 53% by 2014. Likewise, on the right hand, we see that the proportion of public hospitals that provided abortion care also increased over this period from 67% in 2008 to 93% in 2014. However, note that there was no increase in provision of abortion care among public health centers, the rightmost pair of bars, and this raises questions about what actions were needed to address the situation. A more recent study of public facilities in the 6 major regions of Ethiopia, covering 90% of the population, assessed the capability of health facilities to provide basic and comprehensive abortion care using a signal functions approach. The study found that between 2018 and 2020, overall capability for providing basic abortion care increased from 67% to 83%. The capacity to provide basic care expanded at both primary and referral levels. And you see that in the first 3 sets of bars. You see the increases from left to right. However, among referral level facilities shown on the extreme right, and these facilities referral level are expected to be able to provide comprehensive safe abortion care, the proportion doing so did not increase at all. This highlights the need for attention to access to this quality of care. As you can see, data are very useful from these three examples. The data are very useful for highlighting gaps and can be used to argue for improvements in the structure and quality of abortion care within a country. So in conclusion, I want to highlight the potential for model-based estimates of abortion and unintended pregnancy to be used to make the case for improving access to abortion and contraceptive services. The updated global and regional estimates are very relevant for current discussions on laws, policies, and health system capacity and coverage regarding both abortion and contraception. The country-level estimates available for the first time provide important inputs for debates at the national level on the importance of making abortion and contraceptive services available and accessible to all who need them. It's also important to highlight the many innovative study designs and methodologies that researchers are pursuing now to improve data on abortion in particular, and to note that these improved estimates and study designs will provide essential inputs for the model-based estimates, and they are also extremely important for the country's policies and programs themselves. So at the national level, targeted studies and regular ongoing data collection are both highly relevant for monitoring progress and identifying gaps. These data provide the basis for evidence-based and effective policies and programs that can address and close existing service gaps. Thank you very much for your attention.
Thank you, Jelasini, for your nice presentation again. So we have seen how evidence has changed a lot of abortion care service policies and reforms from your presentation, and how data is really essential for other ongoing changes, and also to bring also difference in the current quality of abortion care. So now the floor is open for question and answer. So since time is an instance, like we are trying to answer some of the questions which comes from the chat or from the Zoom and also from the Q&A. So I will forward for the first some questions to Dr. Tesfaye, and then we'll come to Dr. Antonella next. So the first question for Dr. Tesfaye is like, is it legal if the provider give abortion care in a country where abortion is legalized to an individual came from another country where abortion is legally restricted? The second one is, how do you advocate approach of countries that still need to make the move towards legalization of abortion, especially in countries with a very strong religious ties that leads to a view of abortion as a moral failing? So this is for Dr. Tesfaye. Please, Dr. Tesfaye, reflect on these questions. Thank you.
Thank you very much. So as to the first question of accessing abortion by traveling to a more liberal countries or to the more liberal areas. So I think the reality or the fact is, despite the existing law, despite how restrictive the law in the country is, women still try to access abortion. So unfortunately, some of these roads as a woman is taking could be very unfortunate and may take her life in the process. So that's why we need to put an effort to make abortion as easily accessible as possible. So that's a priority. So saying this, there are several studies that describe, women traveling long distances to other areas, regions to access abortion. So I think I can say I didn't came across to any litigation for a woman traveling to an area where abortion is liberal or legalized. But as I've pointed out, the priority should be making abortion as safe as possible, as easily accessible as possible. Otherwise, the other route will be, unsafe abortion, which will take the woman's life. To the second question, increasing access to safe abortion in a country with very strong religious ties. I think what I can share is our country's experience that helped us in, making a change in legal reform. So I can highlight three main points. One is use of data to show how unsafe abortion affects maternal health. So for sure, if abortion is not accessible safely or it's not accessible through legal means, women will take the other road, and that will lead to maternal death. So I think having a strong data that relates to unsafe abortion and maternal health can be one strong point that can help, to bring all, partners, including, even religious individuals, to bring them into discussion, considering relating, the issue of unsafe abortion to maternal health. The idea is using, a human rights approach, and some of ratified countries' protocol which relates to the human rights could be an entry point to start a discussion on legalizing abortion. And the final is, I think, collaboration with relevant stakeholders in the country, bringing all, people who are, reproductive health advocates, and building a strong team in a country can help in, changing an abortion law in favor of the women's rights. So this is basically based on the path we followed as a country. Thank you.
Okay, thank you very much, Dr. Tesfaye. And I have a couple of questions for Dr. Antonella, and this is also from the chat session. So the first one is, what are the implications of abortion decriminalization in Nepal? And the second one is, where, like as WHO says, where abortion is lawful, abortion must be safe and accessible. But what about where it's not lawful? So Dr. Antonella, please respond to these questions. Thank you.
Thank you so much. So for the second one, I actually put a comment in the chat. So that's a human rights standard statement. It's actually not a WHO statement per se. So I would refer people to the abortion care guideline, which provides information related to the multiple actions that are needed at different levels. So that would include legal, health system, and community levels, so that everyone who needs access to comprehensive abortion care can access it. And it covers information around legal and policy regulatory frameworks. For the first question about Nepal and decriminalization, so we don't speak to individual country context, but just in general, it's important to first highlight something that Tesfaye had mentioned in his presentation, which is that decriminalization is not the same thing as so things like murder or manslaughter to abortion, and ensuring that there are no criminal penalties for having, assisting, providing information about, or providing abortion for all relevant actors. And so by doing so, it would potentially impact on this chilling effect that individuals experience because of fear of the law. But also it means that anyone who has experienced, for example, a pregnancy loss won't come under suspicion of illegal abortion when they seek care. We see this sometimes in the Latin American region and others. And it's also important to know that the process of decriminalization does not make individuals vulnerable to things like forced or coerced abortion, because those constitute serious assaults. And so these are non-consensual interventions and are sort of covered separately. So I would say that those are the general implications overall. Over.
Okay, thank you very much, Dr. Antonella Lamnet, for your response to the question. So we don't have any more questions, but I can give some 1 to 2 minutes for the speakers if there's anything that you want to add. So Dr. Tesfaye, you can start, and we can go to Dr. Antonella next.
So I think Dr. Lavlanet has raised her hand. We can give the opportunity for Dr. Lavlanet, and then I can follow.
Sure, please proceed, Dr. Athena Lavlanet.
Apologies for that. I just wanted to add, because I can see that there's a question actually in the Q&A. I don't know if you want to read that out, and then maybe I can just come in really quick.
Okay.
Okay.
So I think from my side, probably one comment from Tanzania. I think the issue of the existing reality in Tanzania and the paper that was discussed, I think, as it has been clearly seen, we are discussing the data out there which was published in 2019. It may not describe the current condition of the country, and the current actual reality could be somehow different. But we used that study to provide the relationship between law and access. And actually, Tanzania, as described in that paper, is an example how providers in collaboration with relevant stakeholders can improve access within the existing law and use it actually positively to improve reproductive health and rights. So I think this experience is quite similar to what we have in Ethiopia.
Okay, so the question from the Q&A session, it's about regarding conscientious objection. What would you advise advocates from countries or policymakers where the law is silent on conscientious objection and the medical practice is guided by the ethical principles? Could you share some of the best practices in other countries dealing with conscientious objection? And I'm wondering whether legalizing conscious objection would be like opening a Pandora box. So you can respond to this, Dr. Lavnaret. Over to you.
Great, thank you. So in general, I would say that we have found that conscientious objection is a barrier to accessing care. There are countries that have specifically put law or policy frameworks in place that in theory would facilitate access where an individual faces a conscientious objector. So there's a couple of examples that I had provided in my presentation, so that could include everything from, even where you have an institution where there are several objectors, the institution is responsible for making sure that there is somebody there who can provide. It means that some countries have created laws where they say that either records or the actual individual person must be transferred to another unit where there is a known provider. The thing is that there is some data at the moment that talks about how this works in practice. And like many things related to abortion, things aren't necessarily working the way they're either intended to or the way the law hopes that they will. So there's a lot to consider there. Introducing something into a law that isn't there, there's a lot of considerations there as well. And again, I would refer you to the guidance just to think about the different ways in which abortion care is regulated. And we are often highlighting that it is typically regulated in a way that's not like other forms of healthcare, which often introduces all sorts of other problems. So I would just comment on that generally. Over.
So if you want to add something on this question, the floor is open to both Sushila and also Dr. Tspai.
Yeah, I think very strong points raised by Dr. Lavlanet, and the issue of consciousness objection, I think it's one big area which needs discussion, experience sharing among different countries. We do have a very good experience of how using consciousness objection to actually increase access to reproductive health. So what I would probably suggest is probably bring this on another session and sharing a ground experience in a country who has benefited, from the real experience. So probably we can prepare another similar session on the area of consciousness objection. Over to you.
Thank you, Dr. Tasfai. Anything that you want to say, Shelasini? So the floor is open to you.
Hello. I didn't want to particularly add on conscientious objection. I would just say that from the experience in Latin America, the need for the medical profession, those who provide abortion, to support each other can help limit or ameliorate the effect of the level of public attention, of sometimes objection to the provision of the service. And there's a lot of pressure on providers, and that can lead to conscientious objection itself, so that to the extent that supports can be built in and sustained, that can be one mechanism for addressing conscientious objection that we've seen at least be some help in this area. Very difficult to deal with. Over.
So thank you everyone, especially for our speakers to take your time and give us this outstanding presentation and lectures. And thank you also for the attendees and the participants for your participation, comments, questions. So the link to this session is going to be you can access it from our website. And also then if you have anything to say, then I think we are going to close. So I'll give you 1 more minute.
So I have nothing to add. Thank you so much, everyone. Dr. Diomed is raising some very important conversation, but for the sake of time, I think we can continue this conversation off the record. That's all. I think thank you so much, everyone, for attending this webinar.
Okay, thank you very much, everyone. Have a good night, and also have a good day for some of you.
Thanks, everybody. Thank you.
Bye.
Bye-bye.
Thank you.